children are not a distraction from more important work. They are the most important work. So we should deal with the children with caution, and we should let them play normally with other children in order to develop normally. And we should treat the children and their problems as early as possible in order to not let a more complicated treatment in the future. The development of different apparatus, such as this apparatus, which is an old dental unit, and which is developed to a newer one with intracameral system with a monitor and ITQ unit. The development of old telephone to a new touch tablets doubles, and the development of Edward Hartley angle arch, or a multi-band system to a new Invisalign, or to new invisible aligner appliances, and the development of myofunctional appliances such as Andreessen or Frankel or habit corrector to a new appliance. What is the new appliance? It is the So we do a short review on myofunctional appliances orthodontic concepts. First, we should focus on the breathing through the nose and lips together at rest, correct tongue position, no facial muscles moving on swallowing, and optimal facial development, class 1 occlusion, straight teeth, and better stability for long time. Always, during clinical examination, we should do the body examination, breathing, head, face, mouth, and teeth to be added to your normal routine. And we should follow the child, and the child should need a special maneuver with him in order to gain his cooperation during the course of orthodontic treatment. So always we should accommodate with the child behavior and not use force with him, but we guide him to the orthodontic appliance to gain his cooperation. The lateral positure, such as plump line through external auditory meatus, shoulder, external auditory meatus to the shoulder and hip, to knee and ankle. So we notice that this is a straight line, while here, when there is generalized muscle weakness, or such as mouth breather, we will get a curvature of this line, such as this young lady. There is a software to determine the forward or front view, horizontal view, interpupillary, intershoulder, interhip. This is in horizontal or transverse view, and also the lateral view. After we gain the parameters of the front and lateral view by a special software. When taking the picture in a standard manner, we will get the parameters from this or from these views. We will get all the parameters about frontal and lateral. Also checking the breathing. This can be done by assistant while the patient isn't watching. Breathing, normally, the normal breathing rate is 15 to 20, and it will be greater than 22 for chronic hyperventilation, while 10 to 14 whereas hypoventilation. Also movement of the chest, diaphragm during breathing, and we notice if there is sounds. Facial measurement routine, indicator line, upper lip, lower lip to chin, competence at rest, incisal show, and strain on lip closure. Here are different children with both or all of them have different bad habits. This is example mouth breather. Here we see that there is imbalance between the lips. Okay, so we should notice the bad habit as early as possible to correct them. Here there is incompetent lip because there is incomplete closure of the lip at rest, and there is hyper contraction of the mentalis muscle. Also here there is incompetent lip. So if there is any reverse swallowing or mouth breathing habit in this, or the majority of children have a developing malocclusion, they show sign of incorrect dental and facial development at early age. Parents see the problem but are told to wait until the permanent teeth are present at age 12 to 14 of age before orthodontic treatment. So all those children have a bad habit, whether they are mouth breather or they have reverse swallowing. Here at rest, the lateral view, we can see incompetent lip, and there is interlabial separation done more than normal. And if we ask the child to close his lips, there will be an hyperactivation of oral musculature during swallowing. So it is called reverse swallowing. And there is hyperactivity of mentalis muscles during swallowing. Children, such as this child, has a mouth breather habit or reverse swallowing for those children. Sometimes we see hyperactivation of mentalis and lip crusting. There is also hyperactivation mentalis and lip dryness and crusting. Also hyperactivation of mentalis. All of those children have a bad habit. Also imaging, photography, videography, cephalometrics, and 3D drawing in the airway through lateral cephalometrics or by CBCT. And also we notice the children during sleeping by taking photographs by the parents. The nasopharyngeal obstruction and its effect, usually it will cause, as a summary, malocclusion, crowding, overbite, crossbite, loss of vertical dimension, and also many systemic problems such as behavioral disorders, reduced energy, reduced mental capacity, and add also sudden infant death syndrome, and also attention deficits hyperactivity disorder, in addition to many problems such as TMJ, headache, neck, also ear pain, ringing, fullness, hearing loss, visual problems. All these are side effects of obstructive nasopharyngeal airways. Dr. Chris Farrell from Sydney, Australia, since that time he has been a clinician in private practice in Australia and in England, and he was comfortable with the excessive extraction. He was not comfortable with the extraction technique and required by the orthodontist at that time. So he wasn't satisfied with the extraction technique. So Farrell received much education from John Mew, UK, and Dr. Harold from USA, created influenced by Carl Linier, Professor Hens, and Professor Frankel, all of whom were looking behind the teeth and onto the faces, muscles, and even the body posture. So he is affected by those scientists. Observation and extensive study of research over the years show that extraction of teeth didn't resolve orthodontic crowding and craniofacial discrepancies. He realized that newer technique had to be developed to treat these many patients more effectively. No practices treating children and adults for orthodontics and TMJ exclusively. Dr. Farrell holds the worldwide patent for the new appliances and is developing other innovation in his practice in Queensland, Australia, specific to the early treatment of orthodontic problems in children and TMJ disorders in adults. So he focused on an early treatment for the children to solve the future expected problems in his dentition and oral and the face, circumoral musculature and the face. Myofunctional research company, causes of malocclusion. So the breathing disorders is the major cause of malocclusion, poor jaw growth, and TMJ disorders. Treatment plan: the Myobrace myofunctional orthodontic system targets airway dysfunction, habit correction, and arch expansion and dental alignment to one integrated system to resolve the craniofacial and orthodontic problems. How Myobrace appliances work? In 1989, Myofunctional Research Company has pioneered the use of single-size prefabricated appliances using myofunctional habit correction while the child is still growing to improve the jaw development. The fundamentals key to this treatment are obtaining correct nasal breathing, correct tongue rest position, and retaining the oral muscles to function correctly, and along with the habit correction. Myobrace appliances apply light forces to the teeth to assist the teeth to align to their natural position, usually with no need for braces or extraction. The appliances are worn for just 1 to 2 hours each day, plus overnight while sleeping. A successful treatment outcome requires good patient compliance. There are 3 to 4 stages of appliances that are designed for each dentition, which are specific to each age group. The Myofunctional Research Company, their treatment goals correct the nasal breathing and correct the functional orofacial musculature position and correct arch form and tooth alignment and producing lip together at rest and correct swallowing behavior. Myofunctional orthodontic concepts concentrated on breathing through the nose, lips together at rest, correct tongue position during rest and swallowing, no facial muscles moving during swallowing, optimal facial development as a whole, a class 1 occlusion, and straight teeth and better airway focus orthodontics, airway focus diagnostics, prevention, undo the damage already done, establish good oral habits, which is very important, and interdisciplinary treatment, retaining proper oral rest posture, oral function, and other good health habits for a lifetime. The Myobrace since 1989 and developing their products with time. They started with the trainer system, the precursor to the Myobrace system, and the TMJ system for treatment of bruxism and temporomandibular joint disorders, arch development, improve the relationship of the jaws and develop the arches. Then the Myobrace was produced to the market, advanced myofunctional orthodontic appliance range, and Myoza also training of breathing, myofunctional and TMJ, and Myotalia, which improved the strength and tone of the airway and orofacial. The ortho trainer, why wait? Their principle, why wait for orthodontic problems to develop? So it was daily use for 2 to 10 years old, between 2 to 4 years, 2 to 10 years old. Sorry, Myofunctional Research Corporation produced the world's first use of 3D solid modeling and stereolithography on intraoral appliance. The trainer influence of the pre-orthodontic trainer treatment on the perioral and masticatory muscles in patients with the class 2 division 1 malocclusion. So the pre-orthodontic appliance show a positive influence on the masticatory and perioral musculature, as a research published by the European Journal of Orthodontics in 2011. The trainer system, which is the precursor or the early version of Myobrace, all focus on habit correction to improve the facial and dental development, such as T4K, the pre-orthodontic trainer, which improve the facial and dental development in the growing child. It is used for trainer for kids during the mixed dentition. Then they produce another type also, the trainer for aligns and retains anterior teeth in the permanent dentition, trainer for alignments or trainer for adults, aligns and retains anterior teeth in permanent dentition. Also infant trainer for habit correction to assist development of the teeth and jaws in the growing child. Another type of trainers, which is T4B, which is trainer for braces. It has shields the soft tissue from brackets. Also another type, trainer for class 2, the trainer for class 2 correction, jaw alignment in combination with fixed orthodontic appliance. And also lingua, which train the tongue day and night, soft tissue protection and tongue retaining to its normal. A trainer for kids, T4K, the pre-orthodontic trainer for kids has become one of the most popular and successful product ranges available from Myofunctional Research Company, used for tooth eruption guidance and correction of any malocclusion except class 3, and correction of myofunctional habits, correct breathing and soft tissue dysfunction. It has tongue tag and elevator, and it has lip bumper and has aerofoil base. It is usually trainer for kids. Usually, it is soft and flexible. It assists this aerofoil base, and this type of trainer assists jaw development and position, and opens the bite and decompresses the TMJ. The trainer for kid phase 1 produce a guidance for eruption of the teeth and habit correction, is intended to be used as a starting appliance in the guidance of tooth eruption, and can adapt to a wider range of patients and is suitable for more extreme starting cases. A trainer for kid phase 2, also it has a tongue tag and elevator and tongue guard, also here the tongue guard, and also aerofoil base. It produces the phase 2 arch expansion and continual habit correction, used in the guidance of tooth eruption and correction of myofunctional habit. It is a firmer appliance. It is a harder material. So the phase 1 is soft and flexible, while phase 2 is harder material, providing additional arch development. And while the another type, trainer for alignment for the adult for the permanent dentition, is like the T4K but designed for permanent dentition, for alignment of permanent dentition. It has higher sides in the canine region and to align erupting canines, and the distal ends are longer to accommodate the second molars. The combination of labial bows and tooth channels with the two-face hardness. It has two faces of hardness. Polyurethane material gives good alignment of anterior teeth. Myofunctional effect also retains oral musculature, making it ideal for retention and relapse case. Phase 1 medium hardness, while phase 1 it has medium hardness, while the phase 2 has, which is harder than the phase 1. Both of them are made from polyurethane. Clinical application: retention after orthodontic treatment with the brackets, cosmetic alignment of anterior dentition without brackets, correction of tear alignment in conjunction with the arch developed appliances, anterior dental correction for minor orthodontic relapse, and also class 2 mild and deep bite correction in the permanent. Infant trainer, it has also an air spring here, and tongue tag also, and tongue guard here, the tongue guard, and strap tether. Here is the strap tether. It is an active exercise that encourages your child to chew correctly while using the jaw muscles. Most important, the infant trainer makes your child breathe through their nose and also trains them to swallow and position the tongue correctly. Research clearly illustrates the correct facial and jaw dental growth depends. The other type of a trainer is a trainer for braces, which is used at age 12 to 14 years old. Is both protective of oral mucosa on fitting of full fixed brackets and seriously treats myofunctional habits and TMJ or temporomandibular disorders during orthodontics. It is not bulky, easy to wear, speeds up the orthodontic treatment, improves stability, has upper and lower bracket channels. Here is the channels in the picture to go over the fixed appliances or braces. Routine use with only new banded upper and lower braces. Base extends to cover the second molars. Clinical application: class 2 correction combined with the fixed or functional appliances treat and prevent TMJ problems. Also used for bruxism to limit the bruxism and prevent soft tissue trauma. Class 1 jaw positioning and open position. The trainer for class 2, this is another type of trainer which is used at the age of 12 to 13 years old, is thicker and higher than trainer for braces, making it is more robust. Appliance specific for treatment of class 2 cases before or during fixed orthodontic treatment. Upper brackets channel and extended height locks over braces for excellent retention. Can be used if our braces are fitted. Myofunctional habit associated with class 2 malocclusion are treated by the trainer for class 2. Pre-molded in edge-to-edge class 1 further assist the correction of class 2 malocclusion. Okay, similar to monoblock. So base extends to cover the second molars. Their clinical application correct difficult cases, shields the soft tissue from the braces, pre-treatment for class 2 correction, jaw development, jaw alignment, habit correction, open bite. The lingua, it carries a tongue tag in a single arch appliance, goes over the upper brackets, and can be worn all the day and night. Yes, one single myofunctional training activity focused on retaining the tongue position. So it is for one arch. Upper just goes over the upper brackets. And we are all the time, day and night. Moldable series, the functional trainer. The moldable series trainer for the functional, it has the trainer attributes plus can be molded to fit tightly to the upper arch and locks in the mandible into class 1, retains dental position and has myofunctional effect. The dual layer technology with moldable ethyl vinyl acetate outer skin is heated and fitted to the patient's mouth, more bulky than the single larger trainers, but the fit and retention are better, replaces the need for laboratory made class 2 activator or retainer. It is not widely used right now because during the heating or molding it produces toxic vapor for the respiratory system. Clinical application, customized in under 5 minutes, class 2 correction and myofunctional habit correction, no laboratory fees, no waiting, adjustable by remodeling. Trainer for functional can be used to replace the class 2 correction functional appliances like clock, twin block, and binator. It is cheaper, easy to apply. What is Myobrace system? In a conclusion, the Myobrace system is produced after the trainers. So it is a more modern version than the trainer. It is a global brand established by parent company, Myofunctional Research Company, in 1989, which specializes in the development of intraoral appliances system. It is a preventive pre-orthodontic treatment that focuses on addressing the underlying causes of cracked teeth, poor jaw growth, and sleep-related breathing disorders, often without the need for extraction, followed by braces, but by unlocking natural growth and development of the child. This system involved the provision of a series of removable appliances to children of very younger age. Children of age 3 to 15 years old are eligible for this treatment. What it does, it's break the poor habit. It helps in development of the jaws. It straightens the teeth, optimizes facial development, and improves overall health, and it promotes health. How does it do this? By helping the child to breathe through the nose, also correct the tongue, resting posture, and swallow correctly and keep the lips together. Breathe through the nose, correct the tongue position, swallow correctly during swallowing, and keeps the lips together and maintaining breathing. Myobrace. The advanced appliance system are divided to many types for juniors, for kids, for teens, for as a summary, the Myobrace for juniors used for primary teeth between 3 to 6 years and subdivided into J1, 2, and 3. Myobrace for kids used for during the mixed dentition between 6 to 10 years old, and it is divided into K0 to 1, 2, and 3, 4 division. While the Myobrace for teens used for during the development permanent dentition between 10 to 15 years old, Also, it has 4 divisions from T1 to T4, while the Myobrace for adults used for permanent dentition from its name for the adults for permanent. It is used above 15 years old and divided into 3 divisions, A1, 2, 3, while another type, which is Interceptive Class 3, used for the mixed dentition between 6 to 12 years old, Interceptive 3 and Interceptive 3 and Interceptive 3H. The braces for mixed and permanent dentition above 8 years old. It also has 3 divisions. Treatment process: habit correction, arch development, dental alignment, retention. So the process involves 4 criteria. The Myobrace for juniors exercises jaw muscles, encouraging correct chewing, training correct nasal breathing, correct tongue position, and good replacement for pacifier and dummy, and improving arch development. It has 3 stages, J1, J2, J3, used for the primary dentition between the age 3 to 6 years old. The J1 between 3 to 6 years old for primary dentition, establishing the nasal breathing and habit correction. It is soft and flexible, which increases the compliance and the comfort while adapting to any arch form. It has a flexible material, large breathing holes, lip bumper and tongue elevator, also the tongue tag and air spring base and high sides. The J2, which is used for arch expansion and continued habit correction. Also, its design feature firm material. It is more firm and harder than the J1. It's also smaller breathing holes with lip bumper and hollow tongue tag and tongue elevators and high side. The J3 finalized the alignment, the habit correction and retention. The firmest appliance and is designed to finalize the arch form and jaw development and myofunctional correction as well as retention. The J3 design feature firmest material than the J2 and J1, smaller breathing holes, lip bumper and hollow tongue tag, tongue elevator. Myobrace for juniors, which is used, as we said, between 3 to 6 years old for primary dentition. The direction for use: step 1, hold the Myobrace with the tongue tag facing up, tongue tag usually facing up. Step 2, place the Myobrace in your mouth. Step 3, keep the tongue position on the tongue tag. Step 4, close down on the Myobrace and feel it working to align your front teeth and jaws. Step 5, keep your lips together and breathing through the nose. And the remaining. Another type, which is Myobrace for kids for the mixed dentition, which is used between 6 to 10 years, divided to K1. The K1 habit correction, K2 for arch expansion, while stage 3 finalize alignment and retention. Designed for class 2, division 1 and 2, anterior crowding, upper and lower, deep bite and open bite. Best after upper incisor. K0 usually focuses on establishing a functional airway and initial tongue strengthening in the mouth breathing children, especially during sleep. Its unique feature is a large collapsed breathing hole, which initially opens the oral airway while transitioning to the nasal breathing. The active tongue tag strengthens the tongue, further improving the breathing function. Since almost all children with malocclusion are mouth breathers, most patients in the mixed dentition will require this appliance. Moving to K1, when the K0 is staying in overnight and breathing function tests have improved. Here is a small movie by Dr. Amila Khan.
We transition a patient from mouth to nasal breathing. A key feature of the video is the constant flexible breathing. The idea is that the patient can bypass.
So it has a large collapsible breathing hole to change the patient from mouth breathing to nasal breathing. The K0 design feature collapsible breathing hole, lip bumper, active tongue tag, and tongue elevators and high sides. It is K1. It is made from flexible silicone to adapt to any arch form, poorly aligned teeth, and its flexible nature means that it offers improved retention for nighttime use. The breathing holes assist the transition to correct nasal breathing, and also extended lip bumper discourages with stipples or small projections that discourages strong overactive lip muscles. So the K2 features dynamic core. Here is the dynamic core with a Frankel cage which assists. This is the dynamic core or Frankel cage, which assists in developing the arch form, improving the dental alignment, and also it has tongue tag guards and elevators, and the tongue position to tongue the position properly, and extended lip bumper to discourages strong overactive lip. The K3, it differs from the others. It is firmer version of polyurethane construction, provides excellent tooth alignment and retention, and hollow tongue tag and elevators train the tongue to sit in final correct position and prevent thumb sucking. Extended lip bumper discourages strong overactive lip muscles. The Myobrace for kids as this is published by the company, this is not a case belong to me. The Myobrace for kids used for, as we said, between 6 to 10 years old during the mixed dentition. So graduation of the treatment for each stages and ending with the treatment with very good normal. The Myobrace for teens, which is used between usually for 9 to 13 years in females and 10 to 15 years in males, it is divided into 4 stages from T1 to T4. The Myobrace for teens, designed for Class 2 Division 1-2, anterior apparent level crowding, deep bite and open bite. T1 usually for habit correction, T2 for arch development, and stage 3 for dental alignment, and T4 for retention. The T1 established nasal breathing and habit correction. It is soft and flexible, adapting to any arch form and occlusion, while the T2 for arch expansion and habit correction is designed to achieve arch expansion, promote correcting position and swallow and lip seal, while the T3 for dental alignment, only dental positioner in entire Myobrace range and focuses on dental alignment using individual tooth slots. These are individual tooth slots, sizes from 1 to 7, and finalize T4 for alignment habits, continual habit correction, and the retention. For the developing dentition, as we said, between, this is another case, not belongs to me. Also ending with normal overjet and overbite. The Myobrace for adults, which is, as we said, used between 15 to 17 years old for the permanent dentition, designed for treating malocclusion in adult patients, mild to medium upper and lower anterior crowding, treatment of relapse anterior alignment after orthodontic treatment with the braces, moderate class 2 division 1 and class 2 division. The A1 soft flexible material adapts to a wide range of arch forms, poorly aligned teeth. The soft material allows for better retention, comfortable for initial stages of treatment, while the breathing holes assist the transition to correct nasal breathing, and extended lip bumper trains the lower lips. This is the extended lip bumper. The A2, it has a medium hardness polyurethane, provides arch development and puts small force on the teeth for improving dental alignment. Tongue guard elevators and to train the tongue to position properly, and extended lip bumper to discourage strong overactive lip muscle. The Myobrace for adults, firm polyurethane construction, it is a firm or hard polyurethane version, provides excellent tooth alignment and retention, and extended lip bumper to discourage strong overactive lip position, and hollow tongue tag guards and elevators to retain the tongue to sit into final correct position and prevent. This is another case not belong to me. Treatment for the adults, which ends also to normal occlusion. Another type of Myobrace, which is interceptive interceptive class 3, which is subdivided into interceptive N, interceptive 3, interceptive 3H, and interceptive 3P. While the interceptive for class 2 appliance is used for class 2, while interceptive class 3 is used for class 3. Interceptive class 3, it is used for in the mixed dentition for class 3 cases between the age of 6 to 12 years. As we said, there is interceptive 3N, interceptive 3, and interceptive 3H. The interceptive 3N, the N, interceptive 3N means it has no dynamic core. It provides habit correction and provides nasal breathing. While interceptive 3, it has a property of arch expansion because it has dynamic core, frontal gauge, and also it has, while the stage 3, I3H, H means harder. So it's used for finalized alignment and used for retention. So you know the interceptive class 3 types for the mixed dentition, and there is one type which is called I3P for the permanent. These 3 types for mixed dentition, I3N means no dynamic core, while the interceptive 3H means it is a harder version for alignment and retention. Interceptive 3N, its property is flexible. It has flexible silicone to adapt to any arch form and poorly aligned teeth. It is flexible nature, also means that it offers improved retention for nighttime use. Tongue tag guard and elevators train the tongue to position properly, and small breathing holes and dual arch form prevent mouth breathing, a common problem in class 3. While the interceptive 3, from its name, it has a dynamic core with frontal gauge which assists developing the arch form and improving dental alignment, and it has also the tongue tag guards and elevators train the tongue to position properly, and small breathing holes and dual arch form to prevent mouth breathing, a common problem in class. The interceptive 3, which is a hard type firm polyurethane construction, provides excellent tooth alignment and retention. It's hollow tongue tag guards and elevators to position the tongue to normal position, final correct position, and prevent thumb sucking, and also small breathing holes and dual arch form prevent mouth breathing, a common problem. This is another type notes belongs to me, a case, which is mixed dentition. The patient for Interceptive class 3, Myobrace is used between 6 to 12 years. So the orthodontist or the dentist use the Interceptive class 3 and ending with normal. Another type of Interceptive class 3 is used for P. P means permanent dentition class 3. Appliance that focuses on correction of dental class 3 relationship and development permanent dentition. In developing permanent dentition and also in the permanent dentition. It also provides, so it is called P. It also provides retention for arch form, breathing, and myofunctional habits. It is a firm appliance with a 3 mm offset, making it ideal for dental correction of anterior crossbite of the permanent incisors or edge-to-edge bites. So it can be used in edge-to-edge, anterior crossbite, or edge-to-edge. Anterior crossbite or edge-to-edge. The Myobrace arch development system designed for narrow arch development and anterior crowding. So the bent wire system, which is advocated by the furrow, which is called furrow bent wire system. It has a palatal arch wire used for arch expansion and alignment with a palatal sheath to be inserted, this wire to be inserted to the palatal sheath of the bands. Or we can use a bioblock, and with the bioblock, which is a removal type, and here is the fixed type. Fixed because using bands with sheath, similar to the Gaucherian bands. And here there is a bioblock, which is a removal appliance for arch expansion. In addition, we use with it myolay for bite opening and promote easier arch expansion and faster. Here is the bands with the sheath and the expansion arch inserted into this sheath. Arch development in conjunction with the trainer system. We use trainer system with the arch expander at the same time, and recommended age between 5 to 12 years. Usually we use A1 with the furrow bent wire system for arch expansion and alignment. The Myobrace for braces used for mixed and permanent dentition between 8 years old and above, designed for conjunction with the fixed braces to improve their effectiveness, improve dental alignment, and improve facial development. The B1, B2, and B3. The B1 established nasal breathing and habit correction. It is usually soft and flexible, adapting to any arch form and malocclusion. It has also channels to accommodate brackets and wires, and is particularly suited for initial leveling and alignment. While the B2 for arch expansion and habit correction with the braces, while the B3 retention in combination with the retainers, while the channels for teeth to accommodate vacuum-formed retainers or clear. The concept or the procedures for Myobrace for treatment, as a summary, first is a habit correction. The chief cause of malocclusion are bad oral habits such as tongue thrusting, mouth breathing, swallowing pattern, thumb sucking, bruxism, nail or lip biting, etc. There are many habits breaking appliances available to correct above habits, but the Myobrace habits breaking appliance is unique, a way to combine the action and Myobrace habit breaker maintains the tongue in correct position inside the oral cavity to avoid mouth breathing, correct swallowing pattern, avoids unwanted extraoral musculation. The second step for the treatment is arch development. It's a combination of Myobrace appliance with arch expansion like bioblock or furrow bent wire system. Children over 6 years of age who has underdeveloped jaws are recommended for treatment of this technique. As we said, use A1 with the Farrell bent wire system, and regular use and activation of this appliance expands the neurodeveloping arch, thereby. The second step is dental alignment. This is done during eruption of the last permanent teeth. This Myobrace appliance for teens aligns the teeth into their natural position. If the teeth need further alignment, braces can still be used for a much shorter period of time, which can be combined with the Myobrace for braces. The fourth step is that retention. The final stage of Myobrace treatment aims to ensure good oral habits are maintained, prevent relapse, and avoid need for fixed retainer. The direction of use in general for Myobrace, since Myobrace treatment involves a series of removal appliances, as we said previously, patient compliance is essential for effective results. The appliance must be worn 1 to 2 hours a day, and especially during sleep at night. Follow instructions on the dentist's proper periodic review. Length of the treatment depends on the growth, depends on the cooperation, usually 12 to 24 months. Then monitor growth and price. Another case published by a company. Here is the pre-treatment, here is the after-treatment. Other benefits in Myobrace system treatment not only focuses on the development of the jaws and alignment of the dentition, but also the overall health of the child in a few ways. The treatment process includes diet counseling, which improves the nutrition status of the child. Sleep disorders, breathing or obstruction sleep apnea is a serious condition in pediatric patients, causing many hazardous. Myobrace appliances allows the jaws to attain its natural growth and position of the tongue. Also, it prevents mouth breathing by correcting the airway dysfunction, and thus the Myobrace system improves the overall health of the child or the kid, including better memory conception, as studies show sleep apnea diminishes. Another type is the Myoza. The Myoza range includes sleep appliances suitable for a wide spectrum of people, includes appliances to suit children as young as 2 years old through to adults, as well as specialty appliances for joints disorders and teeth grinding, which are also associated with sleep disorders breathing. There are many types of Myoza. Snorers 1, Snorers 2, TMJ, TMD, TMJ, BDS, TJ, TGH, Myoza J, Myoza Kids. The Myoza J used for juniors and Myoza for kids. The juniors 2 to 6 years old used, while the Myoza for kids used for between 6 to 12 years old. This is a movie for the Myoza as a summary.
Myoza is a myofunctional ring control. SCP and TMJ disorders, rather than just focus on the Myoza range.
This has anterior opening. This harder version.
From granting childhood disorders, right? Lifelong health complications are avoided. The myosa is transferred.
So we see the types of myosa. The snorers, as we said, there are two types, S1 and S2. It has 4 large breathing holes, high sides, tongue elevators, and air spring-based tongue tag, and also promotes optimum jaw positioning. And also tongue elevators. This is the S1, while the S2 also it has an air spring base, and also the tongue tag and tongue elevators promote optimum jaw positioning. This is the S1 and this is the S2. The S2 is harder than the S1. The TMJ, it has also tongue guard and elevators and aerofoil base, tongue tag, and also promotes optimum jaw positioning. This is the TMJ type myosa. The TMJ myosa, from its day, means daytime treatment for diagnosis. It is used for diagnosis of the TMJ problem. It has moldable by the practitioner with anterior orifice or space. It has low profile, hard inner core, and also variable bite opening. So there is an anterior opening inside it. Day means daytime. The S1H hybrid establishes a functional airway and permits active exercises. It features and built-in exercising components and number of other features which make it ideal for moderate to severe breathing disorders or dysfunction. While the S1 establishes a functional airway and improved TMJ symptoms, while the S1M, from M means moldable. It is a moldable version of S1 for optimal overnight retention, has a harder inner core, and soft outer layer that improves overnight retention. The S2 transition to nasal breathing and improve TMJ symptoms to make a transition to nasal breathing with both TMJ and breathing disorders. While the S2M, it is also a moldable version of S2 for optimal overnight wear and improve overnight retention. While the S3 established nasal breathing and correct TMJ dysfunction to finalize the establishment of nasal breathing. Another type of myosa is teeth grinder and teeth grinder hard. This is the teeth grinder and this is the teeth grinder hard. The difference is the teeth grinder hard is a harder version than the teeth grinder. Both of them has easy moldable. The teeth grinder, it is easy moldable, single layer, just single layer, aerofoil base, and promotes optimum jaw positioning. Tongue guards with easily moldable, dual layer, and also promotes optimum jaw position. So the teeth grinder has a single layer, while the teeth grinder hard, it is harder and has dual layer. Myosa for juniors, J, usually it has high sides, tongue elevators, air spring foil base, and tongue tag. Myosa for kids, tongue elevator also it has, and also it has air spring base, tongue tag, and promotes optimum. The TMJ, usually TMJ appliance, and these are old version, and the TMJ MBV and TMD and Broxoguard. The TMJ appliance immediate TMJ symptom relief, while TMJ MVP for mouth breathers and snorers, and TMD, as we said, D for daytime, customized daytime TMJ supplements, while Broxoguard protects your teeth and jaws for nighttime bruxism. So simple diagnosis and symptoms relief for bruxism, TMJ, and the breathing disorder. The myotelia. This is another type of Myobrace. It is used for tongue and lip exercise appliances. It improves the strength of the tongue, lip, jaw, and throat muscles. The types are lip trainer, lip seal trainer, TLJ, TLP. There are two types, soft and hard, and MyoChew. The myotelia system, it is a revolution in active myofunctional appliance therapy, have gained increased attention in recent years. The myofunctional appliances in general, due to their benefits for patient compliance and ability to target all facial muscles groups with precision. Myotelia range draws on myofunctional research companies' 30 years of experience in appliance design to present practitioners with the world's most advanced myofunctional appliance range to actively improve strength and tone of the tongue, lip, jaw, and airway muscles. This is a summary for myotelia by this video. This is the tether and this is the lip trainer. What's the tab? Join. This is the first tube. This is the TLP. Also, there is Maya too. We'll talk about it. This is the lip trainer. This is the lip trainer. Ideal shape, detachable strap, and lip bumper. And this is the lip seal exercise. This is lip seal trainer. And this is lip trainer, and this is the lip seal trainer. This is the dual use, the train board, and also the lip seal pad. The lip trainer, improvement of the swallowing and perioral muscles function, while the lip seal trainer, improvement of the lip strength and lip seal. Myotilia tongue, lip and jaw TLJ. TLJ, improvement of the tongue, lip, jaw, and airway muscles.
look at the myotonic TLJ. Okay,
It is an active oral myofunctional appliance. This is the tube. Air spring. The myotilia tongue and lip press targets improving the tongue, lip, and airway muscles. We review the movie. It is used for the medium and posterior part of the tongue.
the appliance here. The myotonia TLP.
Soft and hard. The Myo-Chew is another type. The Myo-Chew improvement of the breathing, tongue, and chewing function plus oral hygiene. While the Power Guard for braces, non-moldable, is manufactured from medical-grade silicone and provides excellent protection for the teeth and jaws without any molding requirement. Provides exceptional protection and prevents laceration of the lips. Designed to fit over all brands of braces, Power Guard and 4 braces non-moldable mouth-grade is suitable for all sports. No molding needed. Thickened base and braces channel. It has braces channel. The Myobrace activities, breathing activities, also tongue activities, swallowing activities, and lip seal activities. The activity goes to train the patient to breathe through the nose, keep tongue in correct resting position, and also correctly and keep the lips together. Myobrace activities, breathing lightly, breathing pace, head rocking, while the tongue activities, tongue resting in place, tongue click, tongue suction hold, surface bow tongue, fat tongue, skinny tongue, tongue tip ups. While swallowing activities, Myobrace swallowing activity and funny face swallow. The lip seal activities, lip trainer, lip pops, and buffer fish stretch. The Myobrace exercises activities: oral motor exercises, correct lip position and tonicity, correct tongue position and tonicity, correct swallowing activity, jaw exercises, correct body stage and shoulders, breathing exercises, and snoring and sleep. Lip exercises, range of motion, lip retraction, smile, hold for 5 seconds and relax and repeat 5 times. While the lip protrusion, pucker your lips as if you were going to give someone a kiss, hold for 5 seconds, relax and repeat 5 times. Lip retraction and protrusion, smile then pucker your lips, use exaggerated movements, relax and repeat 5 times. Closure, lip press. Press lips tightly together for 5 seconds, relax and repeat 5 times. Lip press and tongue depressor. Tightly press lips around the tongue depressor while clinician tries to remove it. Perform for 3 to 5 seconds, relax and repeat 5 times. Puff cheeks. Fill cheeks with air. Move air from the one cheek to other 5 to 10 times. No air should escape from around the lips or nose. Relax. Also, the lip exercises: make a smile, hold for 3 seconds, relax and repeat the same. Make a smile, then say O-E. Lip pops, say pop, po, p with exaggerated pressure. Lollipop squeeze, hold and squeeze lollipop with lips for 10 seconds. Lip press, press your lips together for 3 to 6 seconds. Make a kiss, hold 3 to 6 seconds. Smack lips together 5 times. Make humming sounds. And drink through a twist. Tongue resistance. Tongue push forward. Stick your tongue as far as you can. Put something flat such as bag of spoon or tongue blade against your tongue. Push against your tongue with the flat object while at the same time pushing against the flat object with your tongue. Hold for 1 to 2 seconds. Repeat 5 times. Tongue push up. Push down on your tongue with the flat object, tongue blade or back of a spoon, while at the same time you push up with your tongue. Hold 1 second, then repeat 5 times. Touch push to the side. Extend your tongue as far as possible to the corner of the mouth while pressing against a tongue depressor. Hold for 1 second. Repeat 5 times. Repeat for each side of the mouth unless instructed otherwise. Tongue inside push. Put your finger against your right cheek about 1 inch to the side of the corner of the mouth. From this inside, push your tongue against your cheek where the finger is touching. Push as hard as you can. Hold it for 1 to 2 seconds. Relax and repeat 5 times. Repeat for each side of the mouth unless instructed. Other tongue exercises: lick lollipop up and down, protruding the tongue outside the mouth. Licking honey or yogurt from sides of the lips. Tongue clicks and popping sounds, holding tongue elevated 3 to 6 seconds. Hold tongue outside the mouth for 3 to 6 seconds. Touch tongue tip to the nose. Push and hold the tongue inside both sides of the cheek for 3 to 6 seconds. Chew a biscuit to make it softy and mushy. Fold and hold tongue tip between lips 3 to 6 seconds. Push against a lollipop on either side, protruding the tongue. Hold 6 seconds. Place Chocos or Cheerios on the tongue tip and left and press against the palate. Say po to ko. Repeated it in the order. Say la la ta ta, shh, s, or brr. Palate exercises: puff cheeks and breathe through the nose while someone presses on against the cheek. Straw blowing: transfer puff balls through the straw from one bowl to another. Blow cotton balls or bubbles in water. Say ah. Say ma ba. Alternating. Say nada, alternating. Eat cold food, ice cream, etc. For jaw exercises: jaw opening: open your jaw as wide as you can until feel a stretching but no pain, holding the farthest open position for 5 seconds, then relax and close your mouth. Repeat open position 5 times. Side to side movement. Move your jaw to the right as far as you can until it pulls but doesn't not hurt. Hold it there for 5 seconds, then relax. Then move your jaw to the left side as far as you can until you feel a stretch but doesn't hurt. Hold it for 5 seconds, then relax. Alternate this right to the left hand side movement 5 times. Increasing circular movement. Move your jaw around a circle, making it move as far in each direction as you can until you feel a stretch but no pain. In this circular movement, you will be increasing range of motion in the all direction. When you have completed a full circle, relax. Repeat the circle movement, circular snoring and sleep apnea. Usually these are 8 minutes of oropharyngeal exercises performed 3 times a day, significantly reduce snoring. Tongue curls with your mouth open, slide the tip of your tongue backwards along the hard palate as far as back as it will go. Repeat 20 times. With an open mouth, press your tongue flat against the roof of your mouth and suck it upwards. Hold for 2 seconds and repeat 20 times. Force the back of your tongue against the floor of your mouth whilst the tip remains in contact with your lower front teeth. Again, you should do this with an open mouth. Pull your cheek out with your finger. Use your cheek mouth muscles to pull fingers back in. Elevate the back of your throat by sounding ah. Once you get better at this exercise, you should be able to raise your uvula, dangling part in the back of your throat without making a sound. Myobrace exercises 2 to 5 minutes in the morning and at the evening. I summarize them. Stretching the lips and cheek by index and middle finger on each side by both hands, similar to an expander or cheek retractor effect. Touch the tongue tip at the roof behind the anterior teeth spot area with mouth opened 1 time, then the mouth closed in 1 time. Touch the tongue tip at the roof behind the anterior teeth spot area with mouth opened 1 time, then with the mouth closed another time, with moving the head to the side of the mouth opened or closed. Touch the tongue at the roof behind the anterior teeth apart and close the lips together. Correct lip positioning. Touch the tongue at the roof behind anterior teeth, the teeth in occlusion, and close the lips together and teeth in occlusion and breathe normally. Touch the tongue tip at the roof behind anterior teeth, the teeth in occlusion, and close the lips together and teeth occlusion, and swallow with funny face. Correct swallowing activity. Shove the tongue tip at the roof behind the anterior teeth, teeth apart, and close the lips together and swallow with minimum facial expression and movement, then restricted to the throat area only. Practice drinking water with juice with correct technique in front of a mirror. Touch the tongue tip at the roof behind the anterior teeth in occlusion and close the lips together and swallow with minimum facial expressions. Then open nostrils widely and breathe from the nose. Practice deep breathing through the nose with remembering and notice chest and stomach area expansion by placing the hand in a stomach, and notice the movement of the tummy during inhalation and exhalation. At sitting, standing, and laying down position, lightly breathing exercises. Repeat point 8. Laying down on the bag, place the plastic case of Myobrace on tummy and repeat inhalation and exhalation. Exercise to stretch, retract, and strengthen the lips and should provide a positive position on the front teeth to provide realignment effect. And exercise to stretch and strengthen the lips and should provide a positive pressure on the front teeth to provide realignment effect with movement of the head up and down to permit patent airway and normal swallowing. Fat skinny tongue, pop tongue, pull the tongue or out skinny and roll it back, fatty tongue, 10 seconds each. Tongue suction, hold tongue at the top roof and do tongue suction and then open the mouth as well. Snoring and sleeping apnea exercises. Push the tongue against the front teeth, then to the roof, and then swallow. Pull the tongue out as far as you can, 10 seconds, and repeat 3 sets. Place the tongue on the roof and suck the tongue when it is on the roof, and moving the head up down for 5 to 10 seconds, and repeat it 3 sets. Roll the tongue right and left to the cheek and repeat 5 to 10 seconds and repeat 3 sets. And drop the tongue down to the floor as much as you can. Repeat 5 to 10 seconds. What are the drawbacks of Myobrace? Child and family must be motivated. For perfection, braces may be needed. So the treatment with Myobrace needs a polyclinic special center, needs patient education, and needs such as this Robina and Sydney Center, colorful childish decoration in the center. Examination room should include this center, examination room, records room, cartoon demonstration on iPads, training group training group halls. These are chairs like balls, games, iPads. This is the examination room, and this is the recording rooms, taking photography. This is for iPad demonstration and telling story about Myobrace. Also, the Myobrace treatment system should involve a special case sheet. There are many applications in iOS or Android system for the activities, but we demonstrated briefly in a previous slide. What does it really work? Research, criticism, evidence-based, randomized clinical trials, agree, disagree. Many authors disagrees on their findings that activated treatment superior to Myobrace in terms of skeletal changes, overjet reduction, facial height, and decrease and profile improvement. Another researchers show that disadvantages of pre-adolescent class 2 outweigh the benefits when compared with the functional appliances treatment during pubertal growth. These burdens include prolonged total treatment time, patient burnout, increased cost, the need for retention until permanent dentition, but there is risk from increased overjet, psychological problems, and traumatic overload. While other researchers agree, and they do different randomized clinical trials, clinical studies, and they concluded as follows. Their findings: cost of Myobrace compared with the androgen activator, significantly less cost, fewer visits, less chair time, and reduced likelihood of emergency visits. Also, the pre-orthodontic trainer significantly increases the amplitude of emergency activity in the temporalis, electromyography activity in the temporalis masseter muscles at clench in patients with the class 2 division 1 malocclusion, and confirmed to levels similar to those recorded for patients with normal dental occlusion. Dental lip seal effects of Myobrace compared with activator, no significant differences between appliances. In successful cases, both improved overjet, overbite, and class 2 molar relationships at 1 year. And comparison of the effect of Myobrace with untreated controls, and they concluded that pre-orthodontic trainer application induces basically dental alveolar changes, and that result in a significant reduction of overjet and can be used for appropriate patient selection. And also had expanded intermolar intercanine with using the Myobraces for more than those on untreated patients. control. The results from the present electromyographs follow a study of a sample with class 2 division 1 malocclusion incompetent lips indicated that treatment with pre-orthodontic treatment appliance showed a positive influence on the masticatory and perioral musculatures when compared to the control, and also significant mandibular growth in anterior and inferior directions, significant variation in the facial divergence and facial convexity, no modification in the functional equilibrium. Also, all these authors agree with their findings. The weak points, the myofunctional research based the treatment philosophy around the hypothesis that soft tissue dysfunction is the major cause of malocclusion and aberrant craniofacial growth. It's correct. The soft tissue and breathing, when the child is young, pre-pubertal growth spurt, the treatment is very similar to the orthotropics. Orthotropics is a science of facial growth guidance. The treatment is focused on the prevention, further lengthening of already too long face due to the maxilla being unsupported, and is based on facial beauty rather than straight teeth alone. The UK licensing authority has suspended the development of this system from clinical practice. It is difficult to find any research or even well-documented cases reports. Many pictures up to the websites that show excellent results. Results are similar to those obtained by standard orthodontics or myofunctional appliances. Treatment is provided short courses of interested practitioners. Training programs runs over a few days, and delegates can become of Myobrace member or certified provider. The main speakers are general practitioners. Myofunctional research company didn't carry out a trial into the treatment methods. Why do dentists accept promotion of the treatment and treat their patients in the absence of evidence or whether the treatment will work? Can patients consent to the treatment in the absence of strength point? It may have potential. It is time for academic researchers to work with the myofunctional research and carry out a high quality trial research. It is more convenient for the patient, made of silicone rubber, contain no acrylic wires, no extraoral components. When during sleep and 2 hours during the daytime, give excellent results as compared to the no treatment, or when a child refuses ordinary myofunctional appliances and could be worn over a Essex retainer. Conclusion. As a conclusion from my lecture, Myobrace system strengthens the teeth in a natural way, avoiding regular orthodontic treatment. Myobrace improves systemic health of the child by correcting hazardous habits. It is the role and responsibility of the dentist to analyze the growth and development of the child and provide appropriate preventive treatment. So my references is from myobrace.com, myoresearch.com, and also from Raphael Center of Integrative Education, alignme.com, myoresearch.com, and special thanks to Dr. Laith Nissan for I took some references and slides from his lecture, and other references from different websites and other researches mentioned in previous slides, and other videos. I summarize the activities from different videos from the internet. Notes belong to me. Thanks for your attention.